Hi, welcome to the introductory video to pharmacology. Now, I don't know what you've heard about pharmacology, but I want you to be assured that you are going to have fun learning this content. In this video, we're going to talk about the nurse's role in safe and effective administration of drugs. So let's start at the beginning. What do you think pharmacology is? Okay, good job answering the question. Now let's take a look at the formal definition of pharmacology. It's the science dealing with the preparation, uses, and especially the effects of drugs. Okay, so probably pretty close, and hopefully you got that answer. Now let's look at what a drug is. Now it can be any chemical substance. A lot of times people think drugs are just things that have to have prescriptions. They must come from a healthcare provider, but they're really not. A drug can encompass anything, any substance that we use in treatment, cure, prevention, or diagnosis of a disease. Anything that helps our patients have enhanced their physical or their mental well-being. So it's not just limited to things that healthcare providers prescribe. It can also be anything from a health food store, a chemical, a vitamin, a supplement. So remember, when you're taking care of clients, you want to make sure that you ask about all the substances that they take. We need complete information in order to keep them safe. So what do you think the ideal drug is? Well, there's three things that we look for. We'd like the drug to be safe, we like it to be selective, and we want it to be effective. Okay, so when we say safe, nobody wants to take a drug that gives them more problems than benefits. We want it to be selective, like with antibiotics. We want them to kill the bugs and the bacteria, but we don't want them to kill the human cells. And we want it to be effective. If we take a drug to treat someone's high blood pressure, we want it to lower their blood pressure. So when you're just dipping your toes into the pool of pharmacology, what you want to think about is this drug safe? Is it going to be selective? And is it going to be effective for my patient? Now, if you gave me a wish list of lots of other things that we could have for the drugs, these are great things to have. First of all is reversibility. And I'm sure you've heard a lot about the opiate crisis. We have a drug called Narcan or naloxone that if someone has an opioid overdose, if you give Narcan, it will bump those opioids off the receptors and bring that patient essentially back to life. So the ability for the drug to be reversible is really important when it comes to safety. Not all drugs are. Now, predictable. I want to know when I give this drug to patient A or to patient B, I'm going to have relatively the same effect. The next one is no adverse effects. Well, that would be wonderful, but that really doesn't exist. All drugs have some negative effects, and so you want to minimize those, but we're never going to reach the no adverse effects level. No interactions. When you take two medications, you have the potential to have an interaction. And when drugs start working together, they can either impact and significantly increase the action of the drug, or they could diminish the action of the drug. And finally, we want it to be cheap and simple. Now, if you think this drug exists, that's all three of those things: safe, selective, and predictable, plus reversible, no adverse effects, no interaction, and cheap and simple. It simply doesn't exist. We try for those things. It's a wish list, and we get as close as we can, but many drugs can't meet all of these criteria. So overall, what is our goal with pharmacology? We've already talked about all the things that we wish a drug could do, and that there is no true ideal drug. So what is our target? Well, we're looking for maximum benefit for the patient with minimum harm to the patient. And really, that's the exciting part about pharmacology. It's not just memorizing drugs and names and side effects and adverse effects. That would be completely boring. What we're looking for is, how do I help my patient get the most from this drug and the minimum harm? And that's where nurses play a pivotal role. So here's another question for you. What determines the strength of a drug response? Okay, now that you've selected your answer, let's look at some of our ideas. Okay, so let's look at the factors of how much of the drug we can get to the site and what are the things that impact it. First of all, the dosage of the medication. And when we say that, we mean the amount of the medication. So if I give a larger dose, more drug will make it to the site where we want it to work. If I give a smaller dose, less will make it. Next, think about the route of medication. I give a much smaller dose if I give the medication IV, intravenous or straight into the vein. If I give the medication orally, it goes through a first pass effect in the GI tract, which we'll talk about more in another video, but just know that for now, the route I give the medication matters. More of the drug will reach a site if I give it in a route like IV or sublingual versus if I give a medication that's swallowed and goes down into the stomach. The timing between doses matters. If I want less drug to get to the site, I just increase the amount of time in between doses. So if I have a patient that's showing us signs of toxicity or that they've got too much of the drug on board, instead of giving it every 4 hours, I'll give it every 6 hours or maybe even every 8 hours. So changing the timing in between doses will affect how much of the drug gets to the site. Now then, every patient is different. I would love to tell you that everything was predictable. If we gave this drug to patient A and this drug to patient B, they would act exactly the same. It never happens that way in my practice. So listen to your patients. When they tell you when they take this medication, they have this weird side effect, believe them because everyone's body is different. Now, diphenhydramine is a common medication like Benadryl. Most people, when they take it, get really sleepy. Some people, when they take it, get really wired up, particularly with children. So just keep in mind, we know what the medication usually does, but always listen to your patients when they tell you what they experience taking that medication. Now, pharmacokinetics starts to sound super fancy, but it's really just how the drug moves through the body. You'll see the words there on the slide, ADME. That just stands for absorption, distribution, metabolism, and excretion. We'll talk more about those later in another video, but how each one of those processes, ADME, is affected manages how much of the drug gets to the actual site of action. The last one is pharmacodynamics, and that's the effects of the drug on the body. So these are two very important pharmacology terms. Pharmacokinetics, that talks about movement, and that's just movement of the drug through the body. Pharmacodynamics is the effects of the drug on the body. What is my specific role as a nurse in pharmacology? Well, first, you have to be really good at assessment. I want you to do appropriate assessment before you give the medication, during the administration of the medication, and after administering the drug. So what does that mean? Well, if I'm going to give a medication like, let's say, digoxin, that's a medication that directly decreases your heart rate. So it'd be really important that I take your blood pressure and your pulse before I give that medication. The general rule is if your pulse is less than 60, then I would hold that medication and contact a healthcare provider. So that's just one example of appropriate assessment before you give the medication. Now, while the medication was being received, if I was giving it IV, I'd want to watch the patient and for any response while I was giving the medication. And then after I gave the drug, I'd be watching for if it was IV medication, I'd be watching their heart rhythm strip to make sure there weren't any weird dysrhythmias or problems happening. So that's just an example with one type of medication, the appropriate assessment a nurse would do before, during, and after. Next, our job is to evaluate the safety of the drug for this unique client. Some specific drugs are really hard on the kidneys or the liver. So if I know the patient is elderly, or no matter what their age, that they're having renal problems, there's certain antibiotics that I would not want to administer without having lab tests. Again, that's that assessment and having a detailed discussion with the healthcare provider to make sure they're aware of this patient's unique characteristics, because safety is always our number one concern. Now, minimizing and evaluating adverse effects is another important part of our role. There's some antibiotics that you give that can be just brutal to your patient. They end up with this syndrome where they have flushing and pain, and we know that we can do some things to minimize those effects. When we talk about the antibiotics, we'll talk about that more specifically. But just know if you knew you were going to be flushed or have some pain, there's things we can do to minimize and evaluate those effects. If we give the medication very slowly IV, that will minimize those adverse effects. If we pre-medicate with something like some acetaminophen, that will also help. So that's another example of I need to know what those possible adverse effects are and do everything I can to minimize them and evaluate if the patient is experiencing them while we give it. And finally, our job is to educate the client and the family, depending on who's involved in the patient's care. So here's the idea. You don't want to run to the patient's room as they're being discharged and give them a stack of papers that are printed off and call that patient education. You have an opportunity to educate your client and or their family every time you give a medication. So everyone learns better in small bites of information that are repeated over time. So that's the best way to educate your patients. Teach them about their medications every time you give them. Help your diabetic clients understand the role of insulin in their blood sugar management. Help your hypertensive patients understand the role of their blood pressure medications, and etc. So there's your overall introduction to what pharmacology is and what your role is as a future nurse in safe and effective medication administration. We're going to talk about the nurse's responsibility and how to safely give medications to your patients. Ready? All right, so what are the 5 rights of medications? If you haven't heard that terminology before, these are really important because if you follow each one of these 5 rights of medication, you will never make a medical error. So I know when I've had to review charts and look at medication errors, one of these 5 rights was not followed. So it's really important when you're learning to be a nurse that you commit to yourself that you'll never take a shortcut, that you'll follow each and every one of these 5 rights of medication. So let's take a look at what these are. First of all, you want to make sure before you give the medication that you have the right drug. Next, it's for the right patient. You have the right dose. You're giving it by the right route, and you're giving it at the right time. Now, all of this information will be included in the physician's order or the healthcare provider's order. So you would be surprised at how many drugs sound very similar or packaged very similar to another medication. So you want to be very careful that you always make sure to read the label on the vial, on the bottle, or the caplet before you give the medication to make sure that you have the correct drug. I can remember when I was a brand new nurse, I was supposed to give IV Lasix, and someone had inadvertently replaced that with a bottle of IV nitroglycerin. I could have caused significant harm to my patient if I had pushed that medication IV. So don't just assume, always take particular care to make sure you read the label. Next, right patient. When you go into the patient's room, you want to ask them for all their medical identifiers. You're going to want to ask them their name and their birth date, just to be sure that you've identified that patient as the correct patient to receive the medication. Now, dosage. Sometimes things change. You want to make sure that the dose that you're giving is appropriate for that medication and for that patient. Right route. Remember that impacts how much drug gets to the site. So you would never want to give an oral dose IV. And timing. Sometimes this can be pretty tricky in the hospital because you're seeing multiple patients, you're giving medications to multiple patients. It becomes very complex to keep everything on time. But you want to make sure that you're giving that medication at the appropriate time in order to keep it as safe for the patient. So those are the 5 big ones: right drug, right patient, right dose, right route, and right time. And I promise, if you make sure that you don't shortcut any one of those steps, you'll always be on your way to giving medications safely. Now, there's some other things that people keep adding to the 5 rights, and they're actually really helpful. So I wanted to talk about them so you have an idea of what those are. First of all, right documentation. If it's a medication that has a certain side effect or adverse effect, I would want to make sure in my documentation that I included that the patient either had signs of that or did not have signs of that adverse effect. You want to make sure that you do the appropriate assessment. And as we learn through the different drug categories and families, I'll help you understand what are the most important assessments to do. You want to evaluate how that patient is responding to that medication. Now, the patient always has a right to education, and lastly, they have a right to refuse the medication. Now, that might seem kind of odd, but remember, it's a therapeutic relationship that the nurse has with the patient. And no matter how much we think a patient needs a medication, they always have the right to refuse. You want it to be informed consent. You want them to understand, be educated as to what the medication is and why they're taking it, but always know that they have the right to refuse any medication. Okay, so every nurse should know the 5 rights for the medication because we're the last line of defense for the patient. I could share several stories with you of things that nurses caught at the bedside because we're a critically important part of the team. We are the person that gives the medication to the patient. So it's our job and our responsibility as patient advocates to make sure that we've thought through all the potential risks for this particular patient. Hi, and welcome to one of our videos about the medications we use to treat hypertension. In this one, we're going to focus on the renin-angiotensin-aldosterone system. We call that the RAS. Now, let's do a quick review of blood pressure categories. You're going to see those appear behind me. Remember that normal is less than 120 systolic, less than 80 diastolic. Now, you're starting to get into the elevated range when you're 120 to 129 or less than 80. Stage 1 hypertension is 130 to 139 or 80 to 89 diastolic. High blood pressure, stage 2, is 140 or higher on a systolic reading, 90 or higher on a diastolic reading. Now, we use the number 180 over 120 to indicate a severe hypertensive crisis. This patient is in immediate and imminent danger and needs to be at the hospital for treatment. So this is just a quick review of the blood pressure categories. If you haven't got a chance yet, make sure you check out our blood pressure video. Okay, now we use lots of different medications to treat hypertension. So I'm going to kind of give you an overview of some of the medications that we use and some study tips. So ACE inhibitors are angiotensin converting enzyme inhibitors, but we just call them ACE inhibitors for short. If you look at their generic ending, they all end in PRIL. So when you're looking at generic names, this will help you remember, like, if you can't recognize what family or category the drug goes into, you want to look for the ending PRIL, and you've got a pretty good chance that it's an ACE inhibitor. Angiotensin II receptor blockers are ARBs, and they end in TAN. And we'll talk about those drugs as we move through the rest of the video. Beta adrenergic blockers are also called beta blockers for short, and they end in OLOL, O-L-O-L. And finally, calcium channel blockers, some of them end in PINE, P-I-N-E. So make sure that you circle those things that we have in quotation in your notes, and that's going to come up very helpful as you're memorizing generic drug names and which family they belong to. Now, some other medications that we use to treat hypertension are sympatholytic drugs. We're talking about drugs other than beta blockers. In other videos, we've discussed sympathomimetic drugs. Those are things that imitate the sympathetic nervous system being stimulated. This is the opposite. So underline the letters L-Y-T-I-C. Lytic means to go against. So sympatholytic drugs will do the opposite of what the sympathetic nervous system does. So since the sympathetic nervous system causes potent vasoconstriction and your heart rate to go faster, sympatholytic drugs will do the opposite. Direct vasodilators are another group of medications that we use to treat high blood pressure or hypertension. They directly vasodilate, and we end up with a lower blood pressure. Now we have another group. It sounds really intimidating, but I promise that it isn't, but it's selective aldosterone receptor antagonists or blockers. The words antagonist or blocker are usually used interchangeably, so don't let that confuse you when you see it. Beta blockers, beta adrenergic antagonist, selective aldosterone receptor antagonist, or we could also call them selective aldosterone blockers, it would mean the same thing. So that gives you an overview of the types of big groups of medication that we'll be looking at through the multiple videos. Now, blood pressure, remember that's the pressure in the blood in the circulatory system, the whole thing, the arteries, the veins, and the capillaries. So that's what your blood pressure is. When you measure a blood pressure, when you use a sphygmomanometer to actually measure a patient's blood pressure, you're looking at the systolic pressure and the diastolic pressure. Now, if you haven't watched our blood pressure video yet, you probably don't know why my hand is moving up and down. But remember, the systolic blood pressure is the number that goes on the top, That's the pressure that the heart pushes against those vessels and the arteries, blood leaving, and the diastolic blood pressure is when that heart is getting its own perfusion of oxygenated blood. So let's look at the 5 key players in your body for maintaining a normal, adequate blood pressure, okay? Number 1 are the arterioles. They're kind of like the control valves. So if we can impact those arterial valves, we can have a really significant impact on blood pressure. So number 1 are the arterioles. Think of them as the control valves for maintaining a certain level of pressure in your system. Baroreceptors. Now these things are really cool. There's these sensory nerves in the carotid sinus and aortic arches. Now, they're kind of like alarms in the hospital. And I know when I worked in intensive care, you would have certain patients that just the alarms kept going off and off and off, but there really wasn't something wrong. So we would kind of readjust the alarms based on whatever that patient needed. Also, in nursing school, you might think of baroreceptors as that kind of friend that every day is a crisis. You know what I'm talking about? You first meet somebody, and they have something that's really distressing, and so at first you feel bad for them, but then day after day after day, you realize every day is a crisis for them? Yeah, well, baroreceptors are pretty sensitive to that too. Just like if I'm dealing with a person that everything's a crisis, you realize that a hangnail is a crisis in their life, you start to not getting real engaged. You stop getting real engaged with them every time they get all distressed. You learn that, all right, I need to just give them some time. Since everything is a big deal to them, I'm not going to get real upset every time they do. Baroreceptors recognize the same thing in the body. Just like that friend that always is elevated and always kind of out of control, baroreceptors can actually reset themselves. Just like in the hospital, nurses can reset alarms to match the patient. When you have a friend who's driving you nuts because they're so crazy, you learn not to get real excited every day with them. Baroreceptors learn that, wow, this person's blood pressure is up all the time, so they readjust their response level. It's a really cool thing about these sensory nerves in the carotid sinus and aortic arch. Now, this is another one of those words that I thought was so fun to say when I started nursing school. Medulla oblongata. It just sounds cool, right? So you should probably say that at home, wherever you are. Just practice it. Medulla oblongata. That's pretty cool. But it's the cardiovascular center of your brain. So we've hit 3 of the 5 key players. The arterioles, they have the major control valves. The baroreceptors, they're those sensory nerves in the carotid sinus and the aortic arch. Remember, what's cool about them is they can reset. They start to realize that we can change that alarm level in the body in regards to blood pressure. And the medulla oblongata, the cardiovascular center of the brain. Let's look at numbers 4 and 5. Now you have hormones, as I say. Hormones that come from the adrenal medulla. Now, the adrenal medulla is in the adrenal gland. So where do you think that is located? Well, the adrenal glands sit on top of your kidneys. They're not part of the kidney, but they sit on top of the kidneys. That's why we call them adrenal glands. Medulla is one of the 2 parts of the adrenal gland. You have an adrenal medulla and adrenal cortex. Now, the adrenal cortex is the one that puts out corticosteroids, glucocorticoids, those other hormones. But when we're talking about maintaining blood pressure, we're addressing things in the adrenal medulla. Okay, so we've got arterioles, baroreceptors, the medulla oblongata, and the hormones from the adrenal medulla. Finally, you've got the renin, angiotensin, aldosterone system. And we're going to dig deeper into that in the upcoming parts of the video. We'll call it the RAS just for short because some of these mouthfuls take a lot of time just to say. But I want you to stop, pause the video, see how many of these 5 key players you can recall without looking at your notes, and try to write them down. Okay, good work. I hope you didn't cheat yourself by not trying to, don't look at your notes until you've really tried to recall those 5 players. The reason that's so beneficial for you is the energy, the mental energy that you put into recall is a good way to encode that information into your brains. Why do you want it encoded? Because information that's encoded successfully gets moved over to your working memory and your long-term memory, and that's where it's going to be available to you when you need it. So it's okay if you try and then you can't remember all of them, then look at your notes. But the more effort you can apply into remembering these things as we go along, the better your results are going to be in the long run. Now, ACE inhibitors. Think back to that RAAS. Hey, if we've got less ACE available, that's cool, because we're not going to have as much angiotensin 1 converted to angiotensin 2, the potent vasoconstrictor and volume expander. So that's how ACE inhibitors work. You see their names in here, pril, 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 pril. There's a key on how to remember. Now, we put a picture of an ace of hearts on there. You're welcome, just to help you remember A for ACE and the heart, that we use these for anti-hypertensive medications. Predominantly, that's one of the main sources we use them for, is for hypertension. We can also use them with some fancier stuff like left ventricular systolic, with or without symptoms of failure. We use it after an acute MI, helps with mortality, which we're all after reducing. We also use this in diabetic and non-diabetic nephropathy and diabetic retinopathy. Whoa, that's a way long list. What are the top two I would remember? Hypertension and after an MI. If I can talk you into two of them, those would be the top two I would choose to remember. That's not an exact complete list, but those two are going to be the most common, so those are the ones I would make sure I knew. Now, I like this because ACE inhibitors have like a lot of side effects, but these are the ones I want you to remember. A is for angioedema. The angioedema means that your mucous membranes are all swollen and you're not going to be able to breathe. So A for angioedema is a bad deal. Cough is for C, and elevated potassium is E. The three side effects I want to make sure you know for ACE inhibitors. A is for angioedema, C is for cough, and E is for elevated potassium. Now, there's also a first dose effect, and we don't want you to use these meds in pregnancy. ACE inhibitors are a negatron, no-go, don't use them in pregnant patients. First dose effect means that they're going to have a precipitous drop in blood pressure. So whenever you see a test question that talks about the initial dose or the first dose, particularly if you know if it's a blood pressure medication, that's what you're worried about, is that really big drop in blood pressure. So first dose effect, I know, remember, repetition is your friend. So first dose effect is a big drop in blood pressure. We don't give these to pregnant women. And the three main side effects spell out ACE: angioedema, cough, and elevated potassium. Why do we care about elevated potassium? Because I don't want to give a patient an ACE inhibitor who's also on another medication that elevates potassium, like a potassium-sparing diuretic. So keep in mind, if a med already has one side effect, I don't want to give them another medication that also has that side effect. All right, there's a key slide for ACE inhibitors. Make sure you come back and review that later on. Now, I think about the side effects. I told you there's a lot of them, right? I gave you the most important ones. You can kind of keep an eye on those. But you're also going to watch about the kidneys. But if I'm going to go for three, ACE is what I'm going to remember. Now, here's your chance. Supercharge your memory, study as you go without looking at your notes. See if you can answer the order. What is the order of the RAAS? Let's take a look at this NCLEX exam level question. Remember this one? The nurse assesses a client who is taking spirulactone, which is a potassium-sparing diuretic. They're taking it daily, and the healthcare provider has just ordered captopril. Which of the following is the most important action for the nurse to take? Okay, now recall what you answered on this question. Which one did you pick? Well, when you looked at these 4 options, now that we've gone over ACE inhibitors, we know that this patient is on spirulactone, which I told you was a potassium-sparing diuretic, just because I knew you were just getting into this. So spirulactone is a potassium-sparing diuretic, and they've now ordered captopril, which is an ACE inhibitor. So now I'm looking at the options. What's the most important action for me to take is always the one that keeps the patient the safest. So do I need to assess the heart rate? No, that's not a problem with spirulactone or really with the ACE inhibitor. That would be more of a beta blocker, so I could get rid of that one. Should I educate them to take the first dose at bedtime? Ooh, that's kind of odd. I'll leave that in. Should I assess the patient for any history of GI bleeding? Yeah, no combination to captopril or spirulactone. And should I auscultate the patient's lung sounds? Based on the topic of this question, I want to keep this patient the safest, so I'm picking between lung sounds and take the first dose at bedtime. Oh, first dose, risk of a big drop in blood pressure. That's why that's the correct answer. Because pretty much if someone's going to have a big drop in blood pressure, we'd like them to already be horizontal on a soft and cushy surface rather than falling. So that's why we encourage them to take the first dose at bedtime. Now this is to our friends, the beta blockers. Look at this. We've got a football player up there. That's an American football player. They're thinking of you as like a linebacker blocker. So it's labetalol, propanolol, atenolol, metoprolol. Those are all some of the olols, examples to help you start to get the idea that that's one way you can remember what beta blockers are. They end in that olol ending. So how do they work? Well, beta adrenergic blockers is the same thing as a beta blocker. We're talking about the receptor. Remember, beta adrenergic receptors, their job is to respond to sympathetic nervous system stimulation. So a beta blocker is a medication that fits into that receptor, but it blocks that response. So if a patient is taking a beta adrenergic blocker, or beta blocker for short, it's going to prevent the stimulation of that sympathetic nervous system and give us the action that we want. See, it blocks the action of the catecholamines. I know you've heard of these, like epinephrine. Think of it like an adrenaline. Norepinephrine is another catecholamine at these beta adrenergic receptors. Because in a healthy body, here's how it works. Say you're afraid, something happens, your body kicks into high gear. Your adrenal medulla squirts out these substances. They race through your body, they hit the receptors on your heart. They make it pump harder and faster. That's what norepinephrine and epinephrine do. But if I'm taking a beta blocker, then I've got a drug that's already comfy, all cuddled in on that beta receptor. So when those catecholamines get squirted out in my body, they race all around, but they cannot bind to the receptors on my heart. So therefore my heart rate is lower and it's not pumping as hard. That's what beta blockers do. They block that reception. They are medications that fit perfectly onto those beta receptors, and they block those receptors from being activated. And receptors that are blocked means you'll get the opposite response. Now, in case that didn't make sense, we'll go into that again. So don't worry if it's just starting to settle in your brain. I promise you we'll get there. See, beta-1 receptor sites are predominantly in the heart. Norepinephrine and epinephrine are the substances that come out of the adrenal medulla, and here's what happens when they squirt out norepinephrine and epinephrine. The SA node of the heart, that's the pacemaker of your heart. When those beta receptors receive epinephrine or norepinephrine, the SA node goes faster. And the AV node and the Purkinje fibers, they also increase their conduction velocity. So what happens is the SA node as a pacemaker goes SA node, AV node, Purkinje fibers. That's how a beat goes through the heart. When you receive norepinephrine and epinephrine near those receptors, zoom, it goes through faster. So your heart rate is faster, and the atrial and the ventricular muscles increase in velocity and conductivity. Well, those are a lot of words. All that means is your heart is going to beat faster and much stronger and harder. which is a good thing, because if my sympathetic nervous system has been stimulated, I'm likely in danger. There's a reason my body is perceiving that I'm going to need to run really fast. So I'm going to need oxygen, I'm going to need that heart pumping fast, and I'm going to need lungs that bronchodilate. Now, bronchodilating is a job of the beta-2 receptors. Now, an easy way that I remember this is that beta-1 receptors are on your heart, and I have one heart. Beta-2 receptors are on my lungs, and I have 2 lungs. So that's how I keep track of where beta-1 receptors are and where beta-2 receptors are. So they get hit with epinephrine from the adrenal medulla, and then what happens is the arterioles dilate in the heart, the lung, and the skeletal muscle. Hey, that's cool, because the arterioles are like the control valves. So they're going to dilate when those messengers, epinephrine from the adrenal medulla, hits the beta-2 receptors, arterioles dilate. Now things are opening wide up. Those bronchi, they're dilating because they know we need more oxygen because we're going to need to run. Think of it as running. The same response happens when you get stressed out, emotional, or mad, but just think of it as if you're going to need physical ability to run. Now, the uterus relaxes. That may seem kind of odd. We're talking about it right here, but let's think about it. If I was trying to run away from something that was trying to kill me, I don't want to drop a baby here. Also, it'll relax my GI tract because I don't want to drop anything out here. So what happens is my gut slows down, my uterus relaxes so it won't push out a baby. Now, what are the odds that this is going to be happening? Not really strong, right? That's just a funny way for you to remember sympathetic nervous system stimulation. Arterioles, they dilate. Bronchi dilate because I need more oxygen. My uterus relaxes because I don't want to drop a kid. And then glycogenolysis in the liver. See, the body is so amazing. It picks up that you need more energy, right? Because if I'm getting to, trust me, if I'm going to run, I need a lot more energy. So glycogenolysis is your body's way of breaking out that stored glycogen into glucose. So remember, when you have excess glucose in your blood, your body takes it in, stores it in 2 places, predominantly your liver and your skeletal muscle. When your sympathetic nervous system is stimulated, it's amazing that your body knows, hey, break out the stored stuff. Right? Genolysis. So lysis, breaking apart. Glycose, standing for the sugar, and gen, to create. So that's what glycogenolysis means, and it happens in your liver. Okay, so you've got a good feel from this slide. That's a lot of information. Let's go back over it to make sure it's solid in your mind. On one side, we have the beta-1 receptor hearts. On the beta-1 receptor sites. On the other slide, we have beta-2 receptor sites. So make sure you have solid in your mind. Beta-1 receptors are predominantly on your one heart. Beta-2 receptors are predominantly in your what? Good. Bronchi, blood vessels, and uterus, which is not going to apply to a lot, but I want it to stick in your mind anyway. So when I get the beta-adrenergic blockers, I'm going to look at impacting the jobs of these receptors in your body. Okay, now this chart is really going to be helpful, so just hang with us as we fill these in. Now you'll notice it says beta-1 receptor sites. Do you see that on the far side of your screen? The title of this is Beta-Adrenergic Blockers Block the Activation of Beta Receptors! Exclamation point, all right? So this is to give you context about what we're talking about. In one column, we're going to talk about what happens at a beta-1 receptor site when it receives or it binds to norepinephrine or epinephrine, what the response is. The next column will say, what happens, if you've given that patient a beta blocker? So the drug will beat those guys to the beta-1 receptor site. So let's look at that again. Okay, if a beta-1 receptor site binds to norepinephrine or epinephrine, the SA node increases the heart rate. But if you've given them a beta blocker, then the heart rate increase is blocked and the heart rate will therefore decrease. So that's an important point with beta blockers. Their heart rate will definitely be lower. Now let me tell you why this matters. Back before I was able to make some lifestyle changes, I was on 5 or 6 blood pressure medications. One of them was a beta blocker. Beta blockers directly decrease your heart rate. So don't ever try to do physical training with an elevated heart rate when your patient's on a beta blocker. So keep that in mind when you're teaching your patients. Don't do physical activity trying to get your heart rate to a certain level. It's going to be a big problem. You'll do some damage to your heart before someone on a high-dose beta blocker can ever get their heart rate up that high. Why? Because you've got the beta blocker drug on the beta 1 receptor, and the SA node cannot respond to the increased demand like it normally would because they're taking a beta blocker. Now, what happens at the AV node and Purkinje fibers? Well, under normal conditions, when norepinephrine and epinephrine bind to that beta 1 receptor, the AV node, remember that's the pacemaker, SA node, AV node, Purkinje fibers, bundle of hit, you got all that going on. AV node and Purkinje fibers, it will increase their conduction velocity. So those fibers will boom, boom, boom. Those impulses will just be tearing through the heart at a much faster rate, unless they have a beta blocker on board. Then that increase in velocity that normally happens when norepinephrine and epinephrine bind to receptor won't happen. So we know their heart rate will be slower, right? Because the SA node increase is blocked. The velocity will not be as intense, so that's another reason why it won't move through. Now again, if we think about norepinephrine and epinephrine getting to the beta 1 receptors on the heart, the atrial and the ventricular muscle will increase in velocity and conductivity. What does that mean? Atrium, ventricle, atrium, ventricle, atrium, ventricle are going to be like atrium, ventricle, atrium, ventricle, atrium, ventricle. They're really going to be a lot more intense, unless the patient's taking a beta blocker. So then the increase in velocity and conductivity is blocked. It's not going as fast and as hard. So you can see, based on what you already know about blood pressure, if the heart rate is slower and it's not pumping as hard, my cardiac output is going to be diminished. Therefore, my blood pressure will be lower. Okay, so that's pretty cool, right? That's really what we want. If we're treating somebody with hypertension, we really want to go after the beta 1 receptors. We would call that medication a selective beta adrenergic blocker or a selective blocker. It will just impact the beta 1 receptors. That's usually what we want. But stop and pause for a minute and think. What other beta receptors have we talked about and where are they located? We have beta 1s on your heart. So where are the other receptors located? You got it. Beta 2s are located on your lungs. Good job. Now, before we leave this chart, make sure it makes sense to you. You've got the receptor on one side, what happens in a normal response when the sympathetic nervous system is stimulated. So make sure you've got a note written to yourself up there above norepinephrine and epinephrine response. That's the sympathetic nervous system response. Over the beta blockers, that's what happens when we give them a med. Now let's take a look at our friends, the beta 2 receptors. Yep, you just answered that question about that. So we're going to look at what happens when epinephrine hits the beta 2 receptors and what happens if you have a beta blocker already on the beta 2s. Now I talked about selectivity. Really what we're looking for is more of the selective beta blockers that would just hit the beta 1 receptors. But in all honesty, no matter what drug you're on, either it's a specific cardioselective or beta 1 selective beta blocker, or if you're on one that's non-selective, it hits both beta 1 and beta 2, you could still experience these beta 2 effects. So keep that in mind when we're talking about patient education. So let's look at what epinephrine does. When it hits the beta 2 receptors, remember it dilates those arterioles of the heart, lung, and skeletal muscle. It's in this diagram too because we're talking about the lung. Now, if you've given the patient a beta blocker, it's going to block that dilation. Okay, here's where this becomes an issue for your patients. Any patient that we send home on a beta blocker, we need to make sure that they understand if they have any breathing problems, they need to contact their healthcare provider. Okay, so for you, beta blockers and breathing problems are bad news. Beta blockers and breathing problems are bad news. So if you're on a non-selective, you're more likely to have a problem, but people who are on a selective one that should just go after cardiac beta 1 receptors on the heart, still might have this problem. Sometimes they're going to need their lungs to bronchodilate, and that action will be blocked if they're taking a beta blocker. So that's why it's really important that you teach your patients, if you have any breathing problems, please contact your healthcare provider. Then they can problem solve with them and assign a different type of medication. Because when it blocks that dilation of the bronchi, your patient might feel really short of breath. And you don't want that, nor do any of your patients. So you make the difference. Educate your patients that, hey, you may or may not have this experience, but if you notice shortness of breath, you definitely want to do something about that. Contact a healthcare provider, probably not take your next beta blocker based on what the healthcare provider advises you to do. Now, the relaxation of the uterus, this is just kind of a talking point in here, not going to be a major factor when you're taking beta blockers for hypertension. We do use beta blockers for sometimes to maybe slow down the process of labor, but that's not the application we're talking about here. Now, glycogenolysis in the liver, remember that breaks down the stored glycogen when a beta-2 receptor is hit by epinephrine. But beta blockers will block this effect. They will block this genolysis. This can be particularly problematic for diabetic patients. See, a symptom of low blood sugar, which is the biggest risk for our patients that are taking insulin, if someone has low blood sugar, what happens is the body kicks into this sympathetic nervous system response. It tells the liver, hey, when this epinephrine goes around and is circulating, it tells the liver to kick out stored glycogen to try and raise that blood sugar. Here's the problem. If the patient's taking a beta blocker, there's two things it won't do. Normal signs of low blood sugar are fast heart rate, and their body's going to try and break out that stored glycogen into glucose for blood sugar. But if they have a beta blocker, you're not going to have that reaction. So the patient's not going to be able to respond to a low blood sugar as quickly and as easily as they normally would because they're on a beta blocker. And the other issue is you're not going to see the tachycardia. Why? Because if the patient's taking a beta blocker, remember, you don't get that faster heart rate. So patients that are diabetic and taking a beta blocker won't show you the typical signs of low blood sugar. So it's very important that you educate your patient and their family members to know that, hey, if they start to kind of show you some confusion, really check that blood sugar, because you're not going to see the normal signs of fast heart rate, and their body's not going to be able to respond as efficiently by breaking out stored glycogen. Now, the last one, enhanced skeletal muscle contraction, which everybody wants, you're not going to have that on a beta blocker. So why does understanding all how receptors work and their response help you? Because once you understand how any receptor responds when it's activated, if we're giving any type of histamine, it's going to be the opposite of that response. There's going to be less of that response. See, this applies to antihistamines, right? And instead of allowing histamine to connect to its receptor, then that's how antihistamines work. Beta blockers are the same thing. Antagonist, blocker, antis, that's what all these drugs do, is they block the response of that receptor. Now, since you know what beta 1s and beta 2s do, you can easily remember how the patient will respond. So the non-selective ones block both beta 1s and beta 2s. That's why they're called non-selective. Labetalol, propranolol, those are two really good examples. Now the ones that are selective, these guys are a little newer and a little more expensive. Atenolol, bisoprolol, and esmolol. Okay, but also keep in mind that even if it's supposed to be selective, with certain patients and different times, they may also have beta 2 stimulated also. The goal is primarily beta 1, but it's not exclusively beta 1 depending on how the patient is doing. So let's pause for just a minute and focus on a question. Let's see if you can remember some easy things. Where are beta 1 receptors located? Good, on the heart. Where are beta 2 receptors located? Good, on the lung. Why do I want a patient with asthma to be on a selective beta blocker? Remember, the benefit for being on a selective beta blocker is we're going to minimize the risk of that asthma patient needing to bronchodilate and having that response blocked. So we probably would look for another medication for an asthmatic patient, but any patient that we put on a beta blocker, we always teach them beta blockers and breathing problems are bad news. But we're talking about calcium channel blockers in this video. So here's kind of how they work. Calcium ion entry into vascular smooth muscle causes vasoconstriction, and entry into cardiac cells increases contractility and conduction, which can increase heart rate. So if calcium moves across those channels, you'll see tighter vessels and increased cardiac activity. So that will help you remember if we give a calcium channel blocker, we're going to stop that calcium movement. So we'll have less vasoconstriction and we'll have a slower heart rate. Both of those should give us a lower blood pressure because that's what calcium channel blockers do. They block that calcium from crossing the myocardial cell membranes and the vascular smooth muscle cells. So we have less vasoconstriction and a lower heart rate when a patient is taking calcium channel blockers. Cool part is that dilates those coronary and peripheral arteries. Well, by dilating those coronary arteries, remember, that's a big help in lowering blood pressure and helping that heart get more blood to it, a good oxygenated blood supply, because those coronary arteries are dilated. Calcium channel blockers don't really have that much of an effect on veins. So think about the word calcium channel blockers. Try circling both A's, the one in calcium and the one in channel, and write the word artery in between your two circles to remind you that that's what they impact, the arteries, not the veins. Now you'll see a note in your drawing, and that will give you a little bit more information about how the SA node is impacted, and you'll see the calcium channel being blocked and what happens in the vessels. So stop the video, pause it for just a minute, take a look at what you see in your notes and in the drawings, and make sure that makes sense to you based on what we've just discussed before you move forward in the video. Okay, now in the calcium channel family, we have several other different families. So I just want to show you how those are broken down, because not all of the calcium channel blockers have the same exact actions. This group, the diphenhydramines, act primarily on the arterioles at the therapeutic level. So if we're giving these medications at therapeutic levels, they primarily act on the arterioles. Remember from our blood pressure video, those are like the control valves. So here's a list of the names that fall under that category. So by this group of drugs, just put a big giant capital A to remind you that they're just the arterioles at therapeutic levels. So I'll introduce you to our first family, the Ds. You've got them right there. Now let's look at the other two families that we have. These act on the peripheral arteries and the heart. So we've got the Ps and we've got the Bs, okay? Those are some long last names for you to say. But these two drugs, verapamil and diltiazem, I really want to draw your attention to. Now, when I'm looking at a list like this and thinking, how am I ever going to keep this straight? Well, look at the last four letters of all the ones in the D family. They all end in what? Good. P-I-N-E. So I can remember the ones that end in P-I-N-E, they're the ones that act primarily on the arteries. But look at verapamil and diltiazem. Yeah, they're way different. They're representative of those two other families, but they act on the arteries and the heart, meaning they will directly decrease your heart rate. So these two drugs, verapamil and diltiazem, will bring your heart rate or your pulse down. That's important to remember. I'm going to get arterioles dilating with all three of these families, but only these two families and the representatives verapamil and diltiazem will also bring the heart rate directly down. Okay, so when you're looking at two big lists like this, look for some way that you can chunk the information and lump it together. That will help you remember more. You can't try and memorize every one of these drug names. It's just not doable. But you can remember, hey, I'm familiar with these drugs. They end in P-I-N-E. That will help me remember that they're primarily on the arteries, and the other drugs, verapamil and diltiazem, go after both. Okay, so calcium channel blockers as a whole increase vasodilation. Now think with me, is that primarily in the veins or the arteries? Good, it's in the arteries, what we just talked about. They'll slow cardiac impulse formation. Now, which two specific drug names will slow cardiac impulse formation and therefore lower my heart rate? Great, diltiazem and verapamil, you got it. So how is the afterload decreased by a calcium channel blocker? Well, anytime I can dilate arterioles, remember those are like the control valves in my blood pressure. So anytime I make those bigger, it's going to be easier for my heart, that left ventricle, to push blood out to the rest of my body. So remember, afterload is the resistance, how tight those vessels are really impacted, how hard the heart has to work the left side of my body to push blood out. If those arterioles are dilated, then it's going to have a lot easier job. Okay, now there's one unusual thing, and I want you to underline that name there. See nimodipine? Underline that. And I want you to write the words vasospasm right next to it, just vasospasm, and help you remember what it is, right? Headache. Okay, I know I'm getting kind of bossy, but the reason I want you to remember this is a really unique property of this particular calcium channel blocker. I had my very best friend in the world ended up preeclamptic, which really developed after she delivered the baby. I know it's kind of odd, but they misdiagnosed with several different things. They thought that she was leaking from her epidural site. They thought she had 4 strokes. They thought what she was having was cerebral vasospasms. So even though she was diagnosed with strokes and MIs, none of that had really occurred. The changes that they were seeing on her tests were cerebral vasospasm. We were thrilled. And then she got a calcium channel blocker like this one to help deal with those excruciating headaches. So by you knowing these things about medications, you can be thinking through, why are we giving this calcium channel blocker? What's our goal? And not just why are we giving this calcium channel blocker, but why are we giving each medication that you give a patient? Because remember, you play a pivotal role on the healthcare team. Now let's look at 3 different areas of calcium channel blockers are used. We just talked about a really specialized one. Can you recall the name of the drug, the special calcium channel blocker that we use for cerebral vasospasms? Good job, nimodipine, you got it. Now try answering those questions without looking at your notes. That will help your brain remember more. But as far as talking about the treatment of hypertension, look, we've got the medications listed there for you. Now, if we're talking about supraventricular and rapid ventricular rate, that's what RVR is, we call those antidysrhythmics. We're going against rhythms. Okay, now, do you see any similarities between the ones that we use for antidysrhythmia and the ones that we use for hypertension? Yeah, 2 of those are the same. But remember, because verapamil and diltiazem are 2 medications that actually go against your heart rate by bringing it down, that's why they're really useful with rapid dysrhythmias. Now, long-term prevention of angina, we've got diltiazem, nicardipine, nifedipine, verapamil, you've got them there. So look at all 3 categories. Is there any medication that's in all 3 categories? Yeah, there's 2. So circle those 2, verapamil, diltiazem, verapamil, diltiazem, verapamil, diltiazem, just to kind of help your brain see the pattern. So we can use calcium channel blockers for high blood pressure, for weird, fast heart rhythms, and for long-term prevention of angina. Now, based on what you know about calcium channel blockers, why would a calcium channel blocker help us prevent angina or chest pain attacks? Pause the video and see if you can write yourself some quick notes. Good work. I'm glad you're hanging in there and trying to answer these questions. I promise that will pay off for you, that you're studying as you go. So, why do calcium channel blockers help us with long-term prevention of angina? Couple things. Dilates those coronary arteries, right? That's a really good move. And it'll also bring down your heart rate with a couple of those. So those will be very helpful in decreasing how much oxygen the heart needs, and we've got that really easy blood flow. So what do you think the side effects are? Well, we know with any family, category, or class, there's some things that are going to be the same. any blood pressure med, patients may complain of a headache. And they might have some dizziness and some weakness. Particularly these calcium channel blockers dilate those vessels, so they might feel a little dizzy. Now you can have some palpitations and some arrhythmias. Remember, these medications go directly after the electrical conductivity system of the heart, so that's why we might have some of these palpitations and arrhythmias. Now, anything a drug does well, it can do over well, so we might end up with a bradycardia, which is slow, right? Tachycardia is fast. Bradycardia is slow. So because some calcium channel blockers, like diltiazem and verapamil, directly go after slowing down the heart rate, it could be too slow for your patient. Also, it could cause, if your patient has some underlying heart blocks, this is not a great medication for them because these meds have the potential to cause bradycardia or possibly a little bit of a type of a heart block. Orthostatic hypotension, we've talked about this in most all of our videos, but that means your patient's blood pressure will drop too quickly if they go from lying to sitting or sitting to standing without pausing a few seconds in between to make sure that their body is adjusting to the change. So in orthostatic hypotension, you need to educate your patients, hey, this is normal. We know you're going to feel this way, but when you go from lying to sitting, do it slowly. Make sure you feel okay before you stand up, because that's going to be really important to keep you safe. Otherwise, you may end up laying back down again really fast on your face, and that's not what we want. Now, this is kind of an uncomfortable topic, but it's really important. You know that the elderly are usually focused on how well their gut's functioning, and if you don't know that yet, you will after you care for them for a while. But if you've never experienced true constipation, you really won't be empathetic, but you need to be, because this is miserable and we can help. We can make sure this doesn't happen and patients don't have to go through this. Because one of the weird side effects of calcium channel blockers is constipation. And the elderly population is particularly at risk. So you want them to stay as active as they can. You want them to stay well hydrated and eat foods that are fresh and healthy and have fiber. Now, I keep putting in the title, both asthma airway problems, both asthma airway problems, both asthma airway problems, because you have to have the first step, foundational understanding of treating somebody with asthma, is that I'm going to have to give them medications that treat the bronchoconstriction and the inflammation. So in that first big green bar, you see the word bronchoconstriction. Make sure you label that number 1. That's what we're going to deal with first. So we have different types of inhalers. By breathing in that medication, I'm going to get the medication right to my lungs where I need it the most. So I have emergency rescue inhalers and I have long-term inhalers. Now they've laid this out for you here beautifully. You have to know the difference. This truly is the difference between life and death for somebody if you know the difference between their emergency rescue inhaler and their long-term inhaler. Now, the reason we've named them emergency rescue and long-term, that's because they're short-acting or long-acting. Now, you see the letters there, SABA. Underline that. Under emergency rescue inhalers, underline SABA. That's just shorthand for saying short-acting beta-2 agonist. Now, you know that you have receptors all over your body, and they do amazing things. But you have beta-1 receptors on your heart, beta-2 receptors on their lungs. Now, when an agonist connects to a receptor, then it does what that receptor is intended to do. Beta-2 receptors are meant to bronchodilate. And if I can't breathe, I need you to give me a short-acting one. I don't want one that's going to take forever to kick in. That would be a long-acting beta-2 adrenergic agonist. So critically important, write your note on this slide that says, know which meds are SABAs and which ones are LABAs. We give people long-acting beta-2s. We give them to those every day to prevent attacks, but they will not save someone in an emergency. You have to be crystal clear on this point. You must know what is a short-acting beta-2 adrenergic agonist, an emergency or a rescue inhaler. It's important that you know it, and it's critically important that you teach a patient and the patient's family, if that's appropriate, which one to use in an emergency. Now, a couple other choices we have for bronchodilators are methylxanthines, and you see that we've got anticholinergics. Those are also very helpful, and we'll talk about how we use those. But the most important part of this slide, when we're talking about one of the two asthma problems, bronchodilators, knowing the difference between emergency and long-term inhalers. I promise you, that could be the difference between life and death for your patients. Now, problem number 2, we're moving into inflammation, when we can use inhaled glucocorticoids. Glucocorticoids suppress inflammation. So by inhaling them, I'm going to get the medication right down into my lungs, which is exactly where I want to target the inflammation. I can also use, look at that, anti-leukotriene modifiers. Sweet! Remember that last slide that you did all that work in and seeing like, oh, those things were released and we had those nasty beasties, and one of them was leukotrienes. So to deal with that inflammatory process, after your patient has been exposed to an allergen, there you have it. There's one of our friends, anti-leukotriene modifiers. They're against what the leukotrienes normally do in the body. By blocking leukotrienes, I'm going to have less of that inflammation and nasty respiratory response. Mast cell stabilizers. Cool. Again, back to that slide. Remember when the allergen in IgE connects to the mast cell and that stuff starts being released? If I can stabilize that mast cell membrane, I'll prevent those things from being released. And last, we have IgE antagonist. Brilliant! That is so cool. Because remember, the very first step was IgE connecting to the mast cells. So here's where it pays off with all the hard work that you did on that slide, looking at the inflammatory process. Inhale glucocorticoids, that will directly suppress the inflammatory response. Anti-leukotriene modifiers will block anti-leukotrienes. Mast cell stabilizers will calm that mast cell down so it won't release those things. And IgE will stop it earlier at step 1. So there is almost a complete overview right there. Now we just need to go back in and fill in the names of the drugs. So if you're feeling like you've worked really hard up to this point, you have. But you have a very solid understanding of how we treat asthma, both of the problems, bronchoconstriction and inflammation. Now, I want you to think, if someone rolled into the ER, just take your finger or your pencil right now, and I want you to put it on the place in the diagram that you feel what would be the most important medication category to give to a patient who rolled into your ER in an extreme respiratory asthma attack crisis. Great. I hope you went right to the section that said emergency rescue inhalers. That's what we're going to do first. That is our top priority because we have to get that airway open. Then we'll address the inflammation and all the other problems, but I want you to be very solid on that concept. Now, you don't even know any names yet. That's okay. We'll lay that in next. Okay, so we've got meds to treat how many problems? Right. Both asthma airway problems. In your mind, define right now what are the 2 asthma airway problems. Write it in the margin of your notes to help your brain remember. 1 should be bronchoconstriction, 2 should be inflammation. So with bronchoconstriction, we talked about the emergency rescue inhalers. You want the short-acting beta-2 agonist. You see 2 examples on your screen now, albuterol and levobuterol. Look, they end in erol, so we know those are going to be beta-2 agonist. Now the longer acting ones, these are inhaled long-acting ones. These are LABAs. They hit the same receptors, the beta-2 receptors, but they take a lot longer to kick in. Now look at the names there. Okay, they end in erol too. But what you want to remember is all that tells us, EROL, just underline that in the names of the drugs to help you remember that. That tells us they're a beta-2 agonist. It does not tell you if it's fast or longer acting, so you want to keep that in mind. Now, remember we talked about the beta agonists, the cholinergic antagonists? This is a combination of a beta-2 agonist, a short-acting one, albuterol, and then a cholinergic antagonist. Now I want you to look back at that other slide. Remember we had the combination of the big green box of bronchoconstriction and inflammation? Look for cholinergic antagonists, and that's where ipratropium fits in. Put those two together and we've got a really effective medication. Okay, now let's look at the inflammatory meds. You're going to inhale glucocorticoids like beclomethasone, dipropionate. You've got, look at this one, ends in budesonide. Then you've got cyclophosphamide. So start to look for a common theme in these medications. They end in SONE or NIDE. Those are the inhaled glucocorticoids. Now, anti-leukotriene modifiers. You can take these by mouth. Remember the role of why we want to block leukotrienes, because they're the one that nastiness in that inflammatory response. So these medications are antagonists. They will block the action of leukotrienes in your body. So you see the names there, they end in, first two end in Lucas, the third one doesn't. So those are a little trickier to remember, but that is their role. They block leukotrienes. Now the mast cell stabilizers are like probably the oldest drug up there, cromulin. This one I'll tell you now, I just want you to write a quick note by this one. Mast cell stabilizer like cromulin is an old school drug, you inhale it, but this is pretty good because it's really safe, so make sure you put the word safe down there, has minimal adverse effects, and it's really good for exercise-induced asthma. If a patient, like if they go to run, they get an asthma attack when they run, if they will take cromulin 15 to 20 minutes before they go and do their exercise, they will likely have less of a response from that exercise-induced asthma. So if a patient is going to do something that exacerbates or kicks in their asthma, if they medicate before that time, we're going to hopefully minimize that reaction. And welcome to another one of our respiratory medication videos. In this video, we're going to discuss COPD. That's chronic obstructive pulmonary disease. Obviously, you can see why we call it COPD for short. Now, COPD is an umbrella term for two other type of disease processes. One is called emphysema, and the other is chronic bronchitis. Okay, we're going to start with chronic bronchitis. Now, you can learn a lot about a disease just from the name. So chronic tells you that this isn't just an acute episode. This happens over and over and over again to your patient. Now, there's 4 letters at the end of bronchitis, I-T-I-S. Now, from your medical terminology, you remember that that means inflammation. It doesn't necessarily always mean infection, but it does mean inflammation. So this tells me I have a chronic inflammation-itis of the bronch. So obviously, it's a chronic inflammation of the respiratory tract, so especially the bronchioles. These patients deal with this really thick, nasty mucus, and therefore they're short of breath because that thick, nasty mucus is filling up their airways, so it's really hard for air to pass through that. Now, a lot of times they have a bacterial colonization in their respiratory tract, so those guys are real comfortable and they just kind of hang out there. So chronic bronchitis is an ongoing problem. It's an inflammation of the bronchioles, and you've got usually bacteria that are colonized in there, and they end up with that nasty, thick mucus. Emphysema is a little bit different. Remember, COPD is an umbrella term for these two disease processes. Bronchitis, which is inflammation of the airways. Emphysema is a different one. These airways are blown up. The alveoli are really damaged and enlarged. If you see in the picture, you can tell normally an alveoli, well, we usually kind of compare it to a cluster of grapes. They're uniformly shaped, they're round, they're open, and they're inflated. In emphysema, those walls have been damaged and enlarged because they're destroyed. So they're not those cute little round shapes anymore. And when they're not those uniform shapes, they just don't exchange CO2 and O2 well. And in fact, air gets trapped in there. And that's why we end up having some major respiratory problems with emphysema. So before we move on, I'd like you to write in the margin of your notes the word COPD at the top. And then write a branch to the right and a branch to the left. Under the right or left branch, you pick, write the word emphysema, and in the other branch, write the word bronchitis. Now, I remember it this way. Bronchitis is gunked up, emphysema is blown up. Either way, the lungs aren't able to function efficiently. With bronchitis, they've got all that thick mucus, making it difficult to breathe and for air to get to where it needs to go. And emphysema, because those walls are damaged, we also don't have good O2, CO2 exchange. So let's look at the overall symptoms for COPD. Emphysema and chronic bronchitis have some sad things in common. Now you see up there, there's our friend Nurse Natalie. She's kind of warm and friendly. I hope she's the type of preceptor you guys get when you go to clinicals, because look how kind she is and patient. So with COPD, you have air trapping. That means I get air in, but it gets stuck down there, so it's hard for me to get new air in because all the real estate is taken up. Now you have damaged tissue for CO2 and O2 exchange. Different ways we got to damaged tissue, but still you have damaged tissue. So the exchange of carbon dioxide for oxygen is not as efficient as it would be in someone whose lungs don't suffer from COPD. So here's the things you're going to see in these patients. Now, I can remember as a new nursing student, the first time I took care of a COPD patient, they seemed really kind of irritable to me. And the classic symptom when you walk in, a COPD patient will be sitting up in bed. They'll be leaned over in a tripod position because that lengthens their chest wall and makes it easier for them to breathe. They usually have an emesis basin. You know, we have those available for patients to brush their teeth and spit in, or if they throw up, but they're usually pretty small, lined with Kleenex, and then they've always got giant phlegm things sitting in those Kleenex. And they can sometimes be a difficult patient to deal with, but here's what you have to remember. They always feel air hungry and short of breath. If they're in the hospital with you, it's because they're having difficulty breathing, or they might be here for another diagnosis originally, but COPD makes everything worse. Another reason why they'll probably be more irritable is the type of medications that they have to take. Sometimes their sympathetic nervous systems are so on overdrive from all the stimulants, it's difficult for them to remain calm. So be very patient with them, and know that when you're dealing with a patient who is in COPD, don't expect them to be like a regular person out on the street. They're really challenged with the things that they're dealing with. So they may request a fan and ask you to, that sometimes helps them to feel better. Just put your best Nurse Natalie face on, remain very calm and kind to them, and you'll help them breathe more better just by the way you deal with it. So I told you have difficulty breathing. They have this cough going on all the time. Lots of times they're coughing up a lot of stuff from their lungs, hence the emesis basin lined with Kleenexes. I think phlegm is my worst, my least favorite thing to deal with as a nurse. There's a lot of body fluids that aren't fun, but that's not really my favorite. These guys live with a lower oxygen level than you or I do. Because they have such difficulty in their lungs, they have poor CO2-O2 exchange, their normal oxygen level is going to be lower than somebody without COPD, and their CO2 level is going to be higher. So keep that in mind. Their arterial blood gas, ABGs, are going to be way different than yours and mine, depending on how far the disease has progressed. So make sure you have that point clear. They're going to have lower oxygen levels and higher CO2 levels. They retain CO2 because of their poor exchange. Okay, now let's get fancy. You guys are sharp enough to figure this out with me. If I have COPD, I'm at an increased risk for right-sided heart failure or cor pulmonale. So before I give you the answer, I want you to pause the video and just think about one thing. These lungs are really, really damaged. Why would the right side of my heart get bigger or have failure because of the lungs being damaged? Okay, welcome back. Let's talk about the answer. Well, COPD or bronchitis, there's some real nasty stuff that happens in those lungs, right? So the pressures are getting higher in your lungs. Well, when the pressure is higher in your lungs, which side of the heart is pumping blood to your lungs? The right side. Remember, right atrium, right ventricle. Wait a minute. Right atrium, right ventricle. Wow, when someone has COPD, that trying to push that blood over to the right side of your heart, it's really having a hard time. So the right side of your heart says, that's it, I'm getting serious. It buckles down and it gets bigger and bigger. Well, that works temporarily, but then it gets so out of hand that the right side of your heart gets kind of floppy and mushy and is no longer as effective. So COPD and other lung problems can cause cor pulmonale. Cor referring to the heart, pulmonale to the lungs. It's right-sided heart failure because of the increased pressure in the lungs. That right side is having to push so hard, it gets bigger to deal with it, and then bigger, and then it's no longer effective. So that's how lung problems cause right-sided heart failure. Good work. As long as you followed along with us, you've got the concept. Otherwise, pause the tape, write it through again just to make sure that you have those steps, because that's a really important point in understanding what happens when one disease causes another problem in your body. Okay, now I love this picture. Isn't that precious? How can you not look at something like that and smile? It's really cool. Well, we're going to talk about bronchodilators. Now, in stable COPD, we're going to use bronchodilators, and we're going to look at short-acting SABAs if they're an acute attack, right? Or maybe some anticholinergics. So we're looking at, I'm going to take a patient who has ongoing COPD, but they're not in an acute crisis. So if a patient has ongoing stable COPD and is not in an acute crisis, maintenance therapy usually involves long-acting bronchodilators, such as a LABA, a LAMA, or both, depending on symptoms and exacerbation risk. Short-acting agents are typically used as rescue medications for symptom relief. Now we're in a crisis, so what are we going to do? You got it. Short-actings, right? Wait a minute, if you've watched our asthma video, which medications do we use for an acute exacerbation there? Short-acting beta-2 adrenergic agonist. So the takeaway point, whenever somebody's in respiratory distress, we've got these bronchodilation issues, we need to open up those airways, SABAs are your answer, right? Doesn't necessarily mean, why do we get there? That's not our most important point. When we know we need to have bronchodilation, a SABA is always going to be the answer. So those were the bronchodilators. Now let's look at the glucocorticoids. Remember, these are never a rescue medication for anyone in respiratory distress. But for stable COPD, we're going to have them routinely on probably a glucocorticoid and possibly with a long-acting beta-2 adrenergic agonist. Now, we don't do these in monotherapy. Mono means one. So you wouldn't be on just steroids by itself. Anyone with respiratory problems is also going to be on a medication that does bronchodilation. Okay, phosphoesterase type 4 inhibitors. Now look at that name there. Underline that because that's kind of a weird one. We haven't talked about that one before. This is for severe COPD. This is one of those special medications that we use just for COPD. Now, cough suppressants. Oh, have you ever had someone in your house have a hacking cough and you're trying to sleep and all you can hear is them coughing? Well, I'm going to talk about what that means. I know when I teach in nursing school and we're proctoring exams and somebody in the room has a cough, I worry about their safety because the students just kind of give them the stare of death when they keep coughing during a test. But you know how it is when you have a cough. The more you try to not cough, the more they seem you need to cough. But let's talk about some over-the-counter treatments. Antitussive means anti, against, tussive, cough. So these are cough suppressants that are available. Dextromethorphan, now it doesn't have any opioid content. It's a non-opioid cough suppressant. It's available over the counter. It's an opioid derivative, but you don't really have the euphoric effect if you take it in a normal dosage. Now, some of you probably already know that this is a drug that can be abused, that particularly in our teenage population, they will drink large quantities of this. And when they drink this cough medicine, they end up like on a PCP-like dissociative mind trip. So this one is another drug that is at risk for abuse. It's available. You usually don't have to show your ID to purchase it. And so if it's abused, you can end up with this PCP-like experience. Now, dextromethorphan is in lots and lots of over-the-counter cold medicines that are combinations. So you always want to be careful when you or a family member or your patients are combining multiple cold medicines because they can overdose on things like Tylenol or dextromethorphan. Now, it is a pretty good antitussive. I know when I have a cold, I use it, but you want to keep in mind, take it within normal doses and don't take multiple over-the-counter cold medicines because you're risking overdosing on that. Now, the next group does involve opioids. Remember, dextromethorphan is opioid derivative, but it doesn't have that euphoria if you take it in an appropriate amount. Prescription antitussives contain codeine, and this is more effective than dextromethorphan, but you have to have a script for it. You'd have to have a healthcare provider write the prescription for you. It is 1/10 the dose that we use for pain in codeine, so you would have to really drink a lot of it to get a super high buzz, but it is very effective in treating your cough. So when it comes to cough, you have an over-the-counter option and you have a prescription option. Both of them are either an opioid derivative or an actual opioid, but remember it's in a much smaller dosage than we would use for pain control. Okay, so let's go back and look at each one of the families. First group, Biguanides. Now, an example of a drug in this family is Metformin. This drug is, you'll see it everywhere. If you've been in the clinical setting yet, I can almost guarantee you've taken care of somebody on Metformin. Now let's look at how it works. It increases the glucose uptake by the muscles and it decreases the glucose production by the liver. That's why you end up with a lower blood sugar. It helps those muscles take up extra glucose and it'll tell the liver, hey, don't make any more glucose. That's what gives us a lower blood sugar. Now, some of the problems with metformin, particularly when you start it, it has some GI distress. You can also have a really rare metabolic acidosis with renal impairment, but predominantly what people are going to see is the GI distress. This is another one of those medications that you do not want to drink alcohol with. And we'll go into that in a little more detail. So we know that this medication is commonly the first type of medication prescribed for a new type 2 diabetic. It used to be that we would try lifestyle first, and do not get me wrong, lifestyle has a huge impact on type 2 diabetes. Staying active and eating healthy, there's a phenomenal benefit for that. In fact, if you really want to delay the progression of diabetes, you want to be serious about your lifestyle change. So we found that when a patient is first diagnosed as being diabetic or even pre-diabetic, we're starting to now prescribe metformin right out of the chute to kind of help give them that extra boost and lowering their blood glucose while they're working on their lifestyle. All of us know that's never an easy choice to make, but I promise you this particular disease is phenomenally impacted if you can help a patient be more active and make healthier choices. Now, metformin may be used by itself, which is considered monotherapy, meaning one therapy, or it can be used in combination with other medications. That'll be determined by the healthcare provider and how the patient is responding. So, metformin is okay to be used by itself. Some of these other ones have to be used in combination. But this drug, so I want to make sure you have that point clear, metformin is okay to be used by itself and used in combination with other medications. Now, there's also some new research coming out that this may become a drug of choice for people with gestational diabetes. Gestational diabetes means a woman who is pregnant who develops high blood sugars during the pregnancy. Sad part about this is if you develop gestational diabetes, you're at a higher risk to develop type 2 diabetes. And it hasn't become practice yet. Normally we use insulin to try and deal with a gestational diabetic client's blood sugar, but metformin is showing promise, so this may be something that you see in the future. Now this is serious, and again, I love the graphic here. Bam! There's a punch to the kidneys to help you remember. People with metformin, if they take it with cimetidine, we've got a risk for lactic acidosis. Brutal on your kidneys. So if someone is taking metformin, they cannot take the other medication, cimetidine, okay? That's an H2 antagonist. We can give them another H2 antagonist that blocks stomach acid for people that have peptic ulcer disease, but they cannot do cimetidine and metformin because it gives them an increased risk of lactic acidosis. So make sure you underline lactic acidosis. And remember, don't miss that boom, that punch to the kidneys. That's a great reminder of the damage it can do to your kidneys. Remember we said don't drink alcohol and take metformin. That's again, bam, that's a punch to the kidneys. Also, here's another very important point. If your patient has a test that involves an iodine-based radiocontrast dye, we do lots of these tests with dye. If they're allergic to shellfish, woo, that's going to be a problem because they'll have an allergic reaction to the iodine-based dye. But if you have this test and the patient's taking metformin, we've got a definite problem. That metformin needs to be discontinued. You see DC there? That means discontinued the metformin 1 to 2 days before the test and for 48 hours afterwards. And you don't want to restart the metformin until you make sure that the kidney function is at baseline. So it's critically important whenever you have a patient who's taking a test with radiocontrast dye, some type of x-ray or CAT scan that's going on, make sure you assess them for being on metformin because we're going to have to do something else to manage their blood sugar for about 4 or 5 days. Now let's talk about what the early signs are of lactic acidosis because that's when you want to catch it. Also, you want to teach your patients that are on metformin what these signs are. So they might have some unusual sleepiness or drowsiness. They'll have a hyperventilation. And if you watch our ABG video, we'll go into more detail. But when you're acidotic, think of CO2 in your blood as an acid, and the body tries to hyperventilate to blow off all that CO2 to bring your pH back more down to normal. So they'll be unusually sleepy or drowsy. They'll try to blow off that extra CO2 to bring the pH back to normal. They might have myalgia and muscle pain. So you want to watch your patient for these signs. Well, what do we do if this happens? Well, we want them to contact their healthcare provider immediately. What we'll end up doing likely is to stop the metformin, of course, and if it's really bad and out of control, the patient may have to have dialysis. So we'd like to catch it before it gets to that point. So you want to educate your patient to look for 3 main symptoms, kind of sleepy or drowsy, notice that they're breathing faster, or if they're starting to have those myalgia or muscle pains. Welcome to our video on diabetic medications. We're going to talk about the risks of insulin. Now, insulin is a hormone that allows glucose to be absorbed by your muscles. They've got a great graphic for you there right on your screen. So take a look at insulin. It's those yellow shapes, and you see they're perfectly shaped to fit into that receptor. When insulin binds to that receptor, it opens up an entryway, and you can see those little blue molecules represent glucose being able to leave the bloodstream and go into the cell. So insulin binds to those receptors, and they're on the plasma membranes of the cell, and tissues can absorb the glucose in the bloodstream. See, that's the problem. If you don't have insulin, you don't have any way to get the glucose from your bloodstream into your cells as an energy source. And that's why a diabetic patient's glucose levels are high. So what do you think is the worst case scenario, the worst possible thing that can happen for a patient who receives insulin? Sometimes people are shocked to learn that we're not as worried about the high blood sugar as we are the risk of low blood sugar for people who are on insulin. Because if they have inadequate glucose, they're going to starve your brain and your body for their main source of fuel. So the symptoms for low blood sugar can range from mild to life-threatening. So the biggest risk for any patient, type 1 or type 2, that's receiving insulin is hypoglycemia. So go ahead and just write that word out again to remind yourself. Biggest risk, WCS. Worst case scenario, low blood sugar. Okay, just a quick review of what the signs and symptoms are of low blood sugar. The patient will become kind of anxious. They might have a headache, or as it progresses, they could even lead to seizures. They might have some neural changes. They might be kind of confused, not be able to think clearly. Remember, we're talking about a finger stick blood sugar that's probably low, like less than 50 low when it gets to that point. Now their heart might start racing. That's because their body's response is to try to hit that sympathetic nervous system to raise that blood sugar by kicking out stored glucose. They're going to feel nauseated or sick to their stomach, really pretty weak, sweaty and tremory. So those are the signs you're looking for low blood sugar. Just a special note, if your patient's on a medication like a beta blocker, you're not going to see that fast heart rate, okay? So you want to remind them to watch their blood sugar really closely. So they're going to feel kind of disoriented, they're going to be confused, they might have some neural changes. If it really progresses, it could lead to coma. Their heart's going to be racing, they're kind of sweaty and shaky. Remember, this is with the fingerstick blood sugar lower than 50. So now we know what hypoglycemia looks like. Let's look at how we treat it in a patient. If they have mild to moderate hypoglycemia, we can just give them some carbohydrate-rich food. Make sure they're able to swallow safely. But if their blood sugar is getting a little low, we just give them a carbohydrate-rich food, and that should help raise their blood sugar. Be sure to keep checking their blood sugar to watch its progress. Now, if there's severe hypoglycemia, we can use IV glucose. That'll raise their blood glucose immediately, right? Because we give it right into their bloodstream. But we only use that in the hospital setting. Let's say they're at home and their blood sugar is drastically low. They can use sub-Q glucagon, but this doesn't kick in as quick. It takes about 20 minutes for a response. So we can use it in home. Let's say you've called the ambulance, you're waiting for them to come. This will encourage the glycogen breakdown in the liver. So they're going to need food when they wake up and they're able to swallow to keep that reaction going, but the sub-Q glucagon will take 20 minutes. Here's the note though. Glucagon will only work best if the patient has stored glycogen. So if they're in a severe malnourished state, this really isn't going to help you. You got to make sure that liver has some stored energy in it, otherwise the sub-Q glucagon won't be helpful. Now, we mentioned it briefly, but I want to go back over that point again. People who are receiving beta blockers, when they drop blood sugar, they have a low blood sugar, you're not going to see that heart rate as elevated, and the body's also not going to be able to break down that glycogen. So people on beta blockers who are also diabetic or receiving insulin, this is something you want them to be very aware of. They're not going to show you the normal signs and symptoms, so they need to be really vigilant in checking their blood sugar. For you observing the patient, if they start to show you some signs of confusion, that is a sign you'll see, and you want to check their blood sugar immediately. Now, there's other medications, if they're taken with insulin, the patient has an increased risk for hypoglycemia. So sulfonylureas and meglitinides, those two drugs will lower any blood sugar. Even if it's already normal or low, it could lower it to really risky areas. We talked about beta blockers. The reason you have falling blood sugar with that one, because your body can't hit that sympathetic nervous system response to break out the stored energy. And lastly, you'd think alcohol that has carbs would make your blood sugar go up, but it doesn't in patients with insulin. Insulin and alcohol, you have an increased risk for low blood sugar. So go through those examples one more time. See if you can answer the question to yourself, why do sulfonylureas and meglitinides cause an increased risk for hypoglycemia? Why do beta blockers cause an increased risk for hypoglycemia? And what's up with alcohol? Will their blood sugar go up or go down? Yeah, sometimes just listening to an educator go through the concepts, I call that bobbleheading in my classroom. People can follow along with me like I'm a bouncing ball in karaoke. But unless you stop, pause, and ask yourself questions, it's not doing you the kind of benefit that you really want when it comes to taking a test and knowing the safest thing to do for your patients in practice. So always take the time to stop, pause a video whenever you want, and ask yourself some questions. Now, there's an elevated blood sugar risk with these medications. So we talked about the medications that put you at risk for a low blood sugar. Now let's look at those that if you use these, they have an increased risk for elevated blood sugar. Thiazide diuretics, glucocorticoids for sure, and sympathomimetics. Now let's go back and talk about why. Thiazide diuretics just have that side effect. That's as complex as you need to get for this. Glucocorticoids will elevate anyone's blood sugar and is particularly problematic for diabetic patients. Sympathomimetics are drugs that mimic the sympathetic nervous system. Remember, that's that epinephrine and norepinephrine that encourages your liver to break out that stored energy when you think you need to really kick it into high gear. Well, sympathomimetics will cause that reaction in your liver, which will therefore elevate your blood sugar. So when I'm thinking about medications that put a diabetic client or somebody on insulin at risk for elevated blood sugar, thinking thiazide diuretics, glucocorticoids, and sympathomimetics. Thank you for watching our video today. You may have found it surprising to think about the biggest risk with insulin is hypoglycemia, but by knowing the risk factors, how to watch for them, and what to do, you can help keep your patients safe. Hi, and welcome to our video, An Introduction to Antibiotics. Okay, when it comes down to antibiotics, it's us against them. And by them, I mean bacteria. So that's what we're going to talk about. How do we win the war against infection? Now, antibiotics are medications that are used to treat bacterial infections. Yeah, let me say that again. Antibiotics are medications used to treat bacterial infections. Viruses cannot be treated with antibiotics. Now, every time we go to the doctor, people usually want to leave with some type of medication. But it's really important that only bacterial infections are treated with antibiotics, not viruses. Now, here's why. You're going to see this ginormous chart come up to review. And I've listed the common reasons people go to the doctor. But I want you to see which one are viruses. And you'll notice in that far column, does an antibiotic needed? It's colored red and the word is no. So a cold or a runny nose, no. Antibiotic isn't appropriate. A bronchitis, no. The flu, no. A sore throat, except strep throat, no. And fluid in the middle ear like otitis media. The answer is still no. Now let's talk about why that is such a big deal. But first, I want to show you lots of examples of bacterial infections that we do treat with antibiotics. In fact, I've listed so many of them for you, it's going to take 2 slides for you to see them. Now, I'm not expecting you to race through all these names, but spend a minute, pause, and see which one of these you've heard. Put a small check mark or circle the bugs that you're familiar with. Ready for the second slide? Okay, now let's talk about antibiotic resistance. That's why it is so important that we only treat bacterial infections with antibiotics, because if we misuse or overuse antibiotics, these bacteria are pretty smart. They can develop the ability to defeat the drugs we designed to kill them, and we've seen it happen over and over again. So the number one reason we want to appropriately use antibiotics, only treat infections that should be treated with antibiotics, they have to be bacterial, is because if we misuse that, if we treat viruses with antibiotics, if we overuse antibiotics, these antibiotics are going to develop a resistance. So that means we're going to start giving the drugs, and the bugs know how to defeat that. So let's walk through that. So how does antibiotic resistance happen? Well, the term antibiotic resistance means you've got an infection that becomes very, very difficult to treat. When you're in your clinical rotations, 2 that you are likely to see are VRE and MRSA. Now, VRE stands for vancomycin-resistant Enterococcus. Yeah, that is a mouthful, isn't it? So, vancomycin is the drug. Resistant Enterococcus means we used to be able to treat the bug, Enterococcus, with vancomycin, but now it's become resistant. Methicillin-resistant Staphylococcus aureus, or we also call that MRSA, that means that that is the bug, Staphylococcus, that is now resistant to methicillin. So MRSA and VRE are two really strong bugs that have become resistant to the drugs that used to treat them. Well, let's talk about kind of how does that happen. Now, they've made a really cool drawing for you. I love what they did with this drawing because it'll really help you understand. First of all, look at the colors of the circles. There's green and it kind of progresses to a red color. That means that the bugs themselves are getting increasingly resistant to drugs. So see how that happens? You start with just kind of all of a variety and they give you an antibiotic. You come in with an infection, you receive an antibiotic, and then the antibiotic kills the non-resistant bacteria. So we're moving from the gentleman in 1 to number 2. Well, now that we've killed the non-resistant bacteria, the resistant bacteria are like having a party because now they start to multiply. Then that person spreads and infects a new person, spreads that resistant bug to the next person, and now it's got the antibiotics fail to kill the resistant bacteria. So using those steps, 1, 2, 3, 4, and 5, that shows you how you go from having an infection, using an antibiotic, and how it can sometimes turn into antibiotic resistance. Okay, now I don't want to trip you out, but microorganisms really are everywhere. I remember when I was in college, we used to share toothbrushes and drinks. One microbiology course cured me of those practices. I don't drink after other people, and I definitely don't share a toothbrush anymore because microorganisms are everywhere. I try not to think about it when I'm pumping gas or using an ATM machine because I know that those are really crazy places for bugs, and especially try not to think about it when I'm at the gym because I know what happens there, but that's a healthy habit anyway. But let's look at the microorganisms that are everywhere because bacteria, like we said, are everywhere. In the air, in the ground, in the water, and they're inside our body and definitely on our skin. Now, not all bacteria are bad, but they multiply very rapidly under favorable conditions. So remember, our body temperature is about 98.6 Fahrenheit. That's pretty warm, and bacteria do very well at that temperature. They thrive. Now, bacteria can be either really good or really bad or kind of innocuous. They're not a big deal at all. So they can either help us or really hurt us or just kind of not bother us at all. We've got them all the way across the spectrum. So as we're entering into this discussion about antibiotics and how we treat infection, keep in mind it's impossible to avoid bacteria completely. They are everywhere. Some of them are fantastic for us, some of them are fantastically harmful to us, but they are everywhere. So what do we do? I mean, let's first talk about the good stuff. Let's talk about how they can be beneficial to the body. Well, E. coli, these are in the gut and they help with digestion. So E. coli in the GI tract, that's really good. We want it in the gut. That helps us synthesize vitamin K. They can also prevent harmful bacteria from taking hold because when I have bacteria that are good for me, like E. coli, they're taking up some real estate. They're taking up some space and the nutrients that the harmful bacteria need. See, that was the problem sometimes when we kill the resistant bacteria. That's how the other resistant bacteria kick in. So how do the good bacteria help us? They take up resources and space to prevent those resistant organisms from taking over. Now, how can I defend myself against infection? Well, we're going to talk about the physical barriers first. Okay, so if my skin stays intact, that's a really good thing. That's one of the great benefits of skin. As long as it's not broken, it helps keep out a lot of nasty bugs. I also have that cilia, right, in my respiratory mucosa. They catch things and they can dump them down into your stomach. That's a really good deal because the gastric acid in my stomach will usually kill those bacteria. So the first two host defenses we're talking about are physical barriers like my skin and the cilia, And the physiological defenses are like the gastric acid in my stomach. Now I've got a killer immune response. If I'm a healthy, functioning immune system, they do some really awesome stuff because the antibodies recognize that bacteria and they mark it for destruction. Then the white blood cells get involved. They come racing in. They're phagocytic. That's a cool sounding word, right? Macrophages and the neutrophils, because the antibodies mark the bacteria, they make it a target, and the white blood cells know to rush in and to take care of them. Welcome to our video on basic principles of cancer chemotherapy. Now we're going to focus on cytotoxic medications. Those are cytotoxic killers. Now, before we get started, I want you to stand up and get a little active. Now don't worry, no one's going to be looking at you, but I need you to put your pencil down away from your paper and stand up next to your chair. Ready? Hey, I can wait till you can stand. Now, I want to teach you, before we get started, I want to teach you the 5 areas of high growth fraction cells in your body. Now, why we're learning this is because cytotoxic medications go after high growth fraction cells. Cancer cells are high growth fraction cells, but I also have 5 main areas in my body that are also high growth fraction cells. See, here's the deal. I wish chemotherapy would just kill the cancer cells, but sadly, it kills all the high growth fraction cells. So we're going to do something that kind of helps you get a jump start on understanding this video, but it's going to involve actions. Don't worry. I'm going to look more ridiculous than you because you can see me and I can't see you. But this is how I help students remember and to learn these concepts. Okay, so let's start at the top. Start with me. Hair. Okay, this isn't going to work unless you actually do it with me. So I need you to touch your head. Hair, GI, skin, reproductive, and bone marrow. Okay, say it with me again. I promise you I'm using research-based concepts, no matter how silly you're feeling. So we're going to go through this multiple times. Hair, GI, skin, reproductive, bone marrow. Say it with me. Hair, no, I'm serious. I need you to do this with me. So let's start again. All right, ready? Hair, GI, skin. What's next? Reproductive and bone marrow. 3 more times quickly. Hair, GI, skin, reproductive, bone marrow. Hair, GI, skin. I heard you say reproductive and bone marrow. Last time, let's see how fast you can go. Hair, GI, skin, reproductive, and bone marrow. Okay, now grab your seat. You did really well. As long as I saw a few of you out there that might not have been with me. But this is what we're doing. First of all, you're standing up and changing your location of studying. Anytime you feel kind of stuck studying, move to a different location. Don't study in the same place every time. Wake your brain up by moving around. Now, I actually did some things that kinesthetic learners actually like. They like movement with their learning. I did things that were, let's say, somewhat annoying, but they also stand out. I didn't just say, reproduction. I said it in a ridiculous voice, but it will stick in your brain better when you do something that makes it stand out to you. I did it in order, head to toe. Hair, GI, skin, reproductive, and bone marrow. Now, when I have to learn a list, one of the things I can do is now take that list. When I know it in my mind, it takes several repetitions so I remember the 5 areas. I do it backwards. So then I'll tell my brain, bone marrow, reproductive, skin, GI, hair. The more you play with that list, going in different orders, starting in the middle, going backwards to the top of the list, all of those things are teaching your brain to look at the concept from multiple different angles. So while it might seem silly, I promise you it's actually based in proven research-based strategies on how you can help your brain remember things. So now you know the 5 areas of high growth fraction cells in your body. Remember, cytotoxic medications kill high growth fraction cells. Cancer is high growth fraction cells, but so are high growth fraction cells in my hair, in my GI tract, in my skin, in my reproductive, and my bone marrow. So let's start from the top and work our way down. You've got cancer that's just unrestrained growth, right? These cells don't follow the rules. So I want you to kind of get a feeling of what makes cancer cancer. Why isn't it, or how is it different than other cells? First of all, doesn't follow the rules. The growth just moves wherever it wants to. You can see it even hopping into that bloodstream, which we'll talk about in just a minute. It just doesn't listen to the feedback mechanisms. Other cells are more polite. They grow at a responsive rate, they respond when they're getting too big and they stop growing. They follow the rules, but cancer cells don't follow any rules because they're invasive. See that cancer cell that's made it into the bloodstream? Well, that's going to let it metastasize. That's when cancer starts in one part of the body and spreads through the lymph and blood into the other parts of the body, metastasis. So if you're thinking about what makes a cancer cell cancer, doesn't play by the rules, unrestrained growth, doesn't listen to feedback mechanisms, it's invasive, and it can spread to other areas of the body. These are the type of cells we're going after. Okay, so what can we do to treat cancer? Nobody wants to hear that diagnosis associated with themselves or someone they care about, but when you have a diagnosis of cancer, we kind of break it into three major categories. We can try surgery, cutting it out. We can try radiation, zapping it out. Or we can try some medications. Now, under drug therapy for cancer, there's three groups. Cytotoxic drugs, those are the ones we're going to focus on. There's hormones, which we're not going to focus on in this video. And there's also biologic response modifiers. But what we're going to learn about in this video series are cytotoxic agents. So know that when you're treating an overall treatment plan of cancer, you could use any combination of these options, surgery, radiation, and drug therapy. But we're going to focus on the drug therapy. Okay, so chemotherapy drugs are more toxic to cells and tissues that have a high growth fraction. Cancer cells have a high growth fraction, which is why we did all that, I'll call it fun stuff, whether you felt like it was that way or not, at the beginning of the video. We've got the healthy high growth fraction cells in those 5 areas that we did together. So take a minute, pause the video, and see if in a separate area of your note, you can write the 5 areas of high growth fraction cells in your body from head to toe. Okay, I'm going to place the answers on the screen for you there, and you see the icons that we chose to help you remember that. Hair follicles, GI tract, skin, reproductive, and bone marrow. So we've got these 5 icons just to remind you, but you've used your own body in learning, and anytime you can do that, that's a great strategy. Let's talk about the ways you can actually receive chemotherapy. They're called modalities. Now we can give intermittent chemotherapy. What happens is, because of the severe effects of chemotherapy, we'll give the patient a dose, and then it will be a matter of weeks before that patient's blood levels are safe enough for us to receive another dose. So we give a dose, you monitor the patient over a period of weeks, and we watch their blood levels, and once they reach a safe level again, we administer another dose. That's intermittent therapy. Receive a dose, wait some time, receive another dose. We can also do combination chemotherapy, where they're getting more than one chemotherapy at a time, and they may be on the same or different schedules. Regional drug delivery means that we can actually deliver the medication very close to the spot of the cancer. So I've listed 3 options for you there. Take a minute, pause the video, and review each one of the 3 spots where we can deliver regional drug delivery of chemotherapy. Okay. Here's your chance to study as you go, supercharge your memory. See if you can answer the questions at this point in your notes without looking back at your other notes. Okay, so in your notes, I want you to answer the question, those 2 blanks. What tissue does chemotherapy target? And then below that, write out again, I know, the 5 areas of high growth fraction. I promise you, repetition is the key to memorizing.